pretty effective. I love the smell of bleach because that tells me things are clean. You walk into a dialysis center, you smell bleach, you know you're in good shape, okay? Because it's clean, yes? So what happens is that the soap and water help to get rid of the virus from your hand. So even if you pick up a virus from a surface, yes, soap and water. Now here's another key factor. For you to get the virus, it has to enter your body. The virus doesn't have little teeth that can bite through skin. Doesn't have that. The way the virus, I'm not doing slides. I'm clicking? It's clicking automatically? No. Okay, well, I'm not doing slides yet. I told you, I'm going off script. The way the virus is transmitted is you take your hand and you touch your face. Specifically, mouth, nose, eyes. So a very good practice for ourselves is to stop doing that. Certainly, if you haven't washed your hands in a period of time, don't touch your face. By touching your face is how you put the virus inside your body, regardless of the surface that it's on. Of course, you could use the sanitizers that the wonderful people over handed out. I think this would be probably the best business card you could ever invent right now. Nobody would get rid of that. So if all the administrators in this room, this is the way to go if you want business development action. Here, right here, business card right here, spritz, everybody's, and then they're gonna have to get a new one, just make sure it's refillable, otherwise they'll chuck it and pick up somebody else's, okay? This is the alcohol. If you look at the ingredients, ethyl alcohol. Does everybody know what ethyl alcohol is? It's the stuff that after the end of the day, when you read about McKnights and all this kind of stuff, you go home and you probably have a little bit so you can get through to the next day. That's what this is made from. So this is really what one needs for self-protection. This, and not to touch your face with hands that have not been very recently cleaned. Now, we don't know where our hands are. They float around. So the best practice, of course, is wash your hands frequently and not to touch your face. Is this new information for anybody? No, this is old information. There's nothing new, okay? Now, I just did it right now. You have to work on it. Now, the next thing we make mistakes is we try to be nice to people. We should be nice to people, yes, of course, but handshaking. Well, if someone goes like this, achoo, and then goes like this, shakes your hand, and then you take and you touch your mouth, guess what? So with all due respect to everyone, even though we're very, very civilized kind of people, it's probably a good idea to stop shaking hands. I think it's less intrusive than wearing a mask in public, to be honest with you, okay? Don't shake people's hands. And fist bump may not be good enough because you could touch your face still. Elbow with clothing on, that's probably the way to go. Or what I don't understand is how they passed the virus in China. Just go like this and everybody understands, hello, how are you? And that will not transmit the COVID, the virus at all. So soap and water, don't touch your face. Now, the people we're surrounded by, we hopefully have some type of etiquette. You know, I was taught when I got married, the fork is on one side, the knife's on the other side. This is the kind of stuff that me as a bachelor, I didn't care. Who's making a difference where the fork is? There's a fish fork, there's this fork. Okay, I didn't know, but thank God I learned. I got married, I learned all about this kind of stuff. So there's etiquette regarding eating. Well, there's etiquette regarding coughing and sneezing. If you have to cough, if you have to sneeze, use this. Or carry around the handkerchief, or carry on a box of tissues. If you see people that don't have that etiquette, 1, 2, thank you so much for your lack of etiquette. Very powerful message, okay? So, and that's part of the problem in closed spaces. Hopefully, most of us are not taking public transportation. I'm not sure about how much people know about not coughing on other people, so we have to be careful about that, and that's why I saw a picture of Grand Central Station yesterday that was in the middle of the day and there was almost no people in there. So, and the last thing I want to talk about regarding the COVID-19 is, if you're sick, stay home. Thank God, in the job that I do, I could probably do a lot of the job I do from home. Now, that doesn't mean I'm going to be home when I should be at work. I'm not going to abscond. I can't. I work all the time. But if you have a position that allows you to work at home, okay? And you are not feeling well, stay at home. If you don't have a position that allows you to work at home and you're not feeling well, stay home. It's not rocket science. And then, of course, your family's not going to have nothing to do with you because you're not feeling well. Maybe you got the virus. So just practice all the things we just talked about, teach them about what I just talked about, and everything should be fine. This is nothing we haven't seen before. This is not Ebola. This is not Spanish flu. Okay, this is not even SARS. Okay, it's coronavirus. We've seen coronavirus before. So let's be cautious about the media hype. That's for multiple reasons. Reason number one, it happens to be the way to sell and have people watch. Reason number two, we're in a contentious election year. So we understand that there's a lot of things that the media is reporting and how they're reporting that have nothing to do with how the public should be getting information. Okay. I think we have a phenomenal, despite the fact that what other people have said, I think we have a phenomenal healthcare system in this country. It's not perfect, but then again, only God is perfect. We have a phenomenal healthcare system in this country, okay? That's why people in other areas of the world, when they get really, really sick and they can pay to go anywhere, they don't go to China and they don't go to France and they don't go to England. They come to Manhattan or they go to Texas, Baylor. They go to a place of an institution. Everybody knows what I'm talking about. So there's a reason why people who can pay come here. There's a small hospital that's in northern New York State, Plattsville, if I'm not mistaken. It's the closest city to Canada. That hospital has a lot of cash-paying patients. I won't let you think about why that might be. Okay? So we have a good healthcare system. So whatever the mortality is in China, it's not necessarily going to be the mortality that's here. The flu mortality in the world is probably around 1%. The flu mortality in the United States is 0.1%. And that's influenza. So we have to recognize we don't have to buy ventilators to take care of patients like they had to do in China, which means a lot of them died before they got those ventilators. Thank God we should have the ability to ramp it up. We have wonderful healthcare departments. We have resources on the federal, the state, the local level. They're working together despite political differences. This is what this country is meant to do. Come together. We can disagree on things. That's great. But at the end of the day, there's certain things we can all agree on, and nobody wants to get COVID-19. Any questions on that? All right, so now I'm going to come a segue. Now, the talk that I was supposed to give, please, it has nothing to do with COVID-19, like I said when this was arranged. So don't think that there's a segue between COVID-19 and what I'm going to talk about, because then that's going to increase panic. So first thing we have to recognize is that we are in a very significantly regulated industry. Does anybody have any questions about that? Yeah, okay. And I'd like to say it's going to get better. I was hopefully when our president got elected, he said he's going to remove 2 regulations for every one that was put in place. I've seen that in other segments. I haven't really seen that in healthcare. Has anybody seen that in healthcare at all? I haven't really seen that. It is what it is. I didn't think it was going to happen in healthcare, and it was never mentioned it was going to happen in healthcare. So based on a McKnight's report from about 2 weeks ago, it's going to get worse, not better, and the penalties are going to get worse, not better. Okay, so we have to recognize it is manageable. All we need to do is communicate and document. Very, very simple. If we're communicating with each other, all the healthcare team members, we're documenting our findings in the patient's medical record, that helps to protect us against a lot of troubles. There has been some changes to the survey process as of yesterday. Okay, CMS sent a nice little love note to all the state agencies that do investigations, basically changing the priorities for how they do investigations. Okay, priority number 1 is IJ complaints. Well, that's obvious. That should always be the first one. Complaints regarding infection control. That is now the number 2. The number 3 are statutory surveys. So that means that a facility that's scheduled for a statutory survey, if the team gets a couple of complaints regarding infection control, your survey may be delayed a couple more weeks. Now, I would venture to say that whatever the survey process is when they come in to do their statutory survey, when they come in, I think they're going to be focusing on infection control. I could be wrong about that, but I can't imagine they're not going to be focusing on infection control. And given all that's going on in this segment in the world over here, IJ is the next statement after that, because if a facility is practicing lousy infection control, in Washington State, there were 5 patients that got sick and died transferred to the hospital and died in the hospital, but 5 from one nursing home. Or it was in assisted living, I'm not sure. But at the end of the day, infection control is going to become paramount. So anybody who's in survey window, which is probably everybody, because we're always in survey window, we need to really, really ramp up our infection control practices. But we can take advantage of the COVID-19 situation by messaging to our staff. First of all, this is really not that much different than flu. But whatever we weren't doing for flu, we need to be doing now. And this way we'll increase our hand washing, hygiene, all that. So this kind of talk that I'm giving to you guys, you need to get your staff engaged in what we're talking about. They're nervous, they're panicked. If they learn this, it's going to increase the likelihood that they're going to wash their hands between patient to patient. It's going to decrease the likeliness that they're going to pick up a piece of bread from the floor and put it back on the patient's tray because they think nobody's watching. And all these kind of things that unfortunately sometimes happen, which are lousy infection control practices. Okay, that's really all I wanted to go off script. Anybody have any questions? So what I'm going to talk about now has nothing to do with COVID-19, so please don't mix those two things up. They are completely unrelated. So in addition to being an internal medicine doctor, I'm also a hospice and palliative care physician. And there's a lot of need for goals of care in our patient population. Most of the patients we're taking care of are sick. The days of admitting a hip fracture with no medical problems to a skilled nursing facility, getting them out in a week or two, even though it would be a great situation for PDPM nowadays, those days are done. Then from hip fracture, they're going home. They're not even coming to a skilled nursing facility. The only way they're coming to a skilled nursing facility if they got congestive heart failure and COPD and diabetes that's not well controlled and all the other things that come with that. So we are taking care of sicker patients than we've ever taken care of before. Anyone who's in this industry longer than 10 or 15 years knows exactly what I'm talking about. So the patients are sicker, and it's very, very important for us to understand that New York State did pass a couple of laws a number of years ago. I know it's 2011, it's a long time ago. Everybody did receive a Dear Administrator letter. It's on the website, and all the physicians received a Dear Physician letter. And it talks about certain laws called Palliative Care Information Act. And I want to distinguish basically what is the New York State law regarding palliative care. Let's just talk about that, okay? Then I want to differentiate and maybe discuss differences between 3 terms that serve a lot of confusion: palliative care, hospice, and what I'm going to put in quotes, comfort care. The third one is understanding residents' rights regarding advanced care planning. And the fourth one is MOST, medical orders for life-sustaining treatment. So just quickly, the Palliative Care Information Act is for doctors and nurse practitioners. And basically that law in 2011, just to summarize quickly, once you as a physician or a nurse practitioner determine that this patient is terminal, you are obligated to have it's amazing they had to pass a law to state the obvious, but it is what it is. You are obligated to discuss with the patient and or their surrogate options for treatment. Now, options for treatment would include whatever curative options are there to help the patient, even if they have a terminal illness, and other options for treatment include things like palliative care, symptom focus, or even hospice. This is an obligation on every doctor and nurse practitioner in New York State since 2011. Unfortunately, like the state usually does, they pass laws, but they don't understand that the healthcare system, the doctors weren't taught about in 2011. The doctors who were practicing in 2011 who finished their training 10, 15 years before didn't learn about this at all. Now, while you may have some physicians that are phenomenal communicators, hopefully they are your medical directors, okay? We understand sometimes we're not necessarily dealing with the best communicators in the world, and we thank our nursing staff often in our facilities that unfortunately carries the weight for a lot of the lack of communication on the doctor's side, which is not ideal. We have to understand that, but thank you to all the nurses in the room that do that for us on a daily basis. So it's the attending health practitioner that is responsible for having this conversation, or any other healthcare practitioners, doctors, nurse practitioners taking care of the patient. It's not just the attending's responsibility. Now, the medical team can designate one person, one practitioner to have that discussion, i.e., the primary care doctor is going to do it. Maybe it's a renal patient, the nephrologist is going to do it, or maybe they're going to have a palliative care consultation done. That's all okay. But the discussion has to happen. Nurses should be in the room, social workers should be there. This should be interdisciplinary, but the key factor is the discussion has to be had by a doctor or nurse practitioner. Having a social worker, with all due respect to social work, we love the space social work do, alone do this meeting is a problem. Why? Because the social worker is going to base what they see. Doctor has diagnosed you with a terminal illness. And the patient's going to ask, or the family's going to ask, am I dying? Okay, well, that's it. What's the social worker going to say on that? Why am I dying? What happened? What's my diagnosis? Not even a nurse can answer those questions unless it's very, very clearly written in the medical record. That's what we call beyond the scope of practice. So physician and practitioner, nurse practitioner engagement in this process is essential for success. And many times I see goals of care discussion that happen, and part of the reason they don't happen well is because the family is not really understanding the medical facts. I can't tell you how many patients that I have personally, families met with, have come from wonderful hospital institutions. Some of arguably those best ones that people fly to from other countries to come to get care. And yet they don't really understand what's going on. They'll be on a chemotherapeutic drug. In the documentation from the hospital, it says palliative chemotherapy. But that palliative word is not used. The family doesn't know about that. They think it's curative chemotherapy. So what I do is I get on the phone, I call the oncologist, I clarify if there's an error in the medical record, and if in fact it's palliative chemotherapy, which I have to understand what that means, because as a palliative care doctor, I can challenge them on that fact. Chemotherapy, I'm not going to, palliative chemotherapy, an ID doctor once said, I'm giving palliative antibiotics. You can give antibiotics up to the day's long. Once you put palliative in front of it, now that's my expertise. Now we need to have a chat, okay? And of course, they didn't, so when you talk to the doctors, they'll say, like the palliative chemotherapy, oh, well, I didn't really discuss that so much with the patient, or I mentioned it like once in passing as my hand was on the door. This is what goes on in our industry. So of course we're going to bear the brunt because they live with us, these patients, for either a short period of time or a long period of time. So that communication factor is essential. We have to clarify misconceptions. Because if we don't clarify misconceptions, how are we going to get appropriate goals of care? That's why the law is on doctors. Now, what's a terminal condition? That's by definition. That's a Medicare definition, okay? Basically, in 1983, Medicare passed the hospice benefit and defined what a terminal patient is. And that's a patient that in the reasonable thoughts of a doctor or a nurse practitioner, actually the only certification has to be a doctor, by the way, not a nurse practitioner, but in the reasonable thoughts of a physician, this patient's prognosis is 6 months or less. Now that's very interesting verbiage, reasonable. That's because, you know, half of Congress are all attorneys. Reasonable, what does reasonable mean? Well, does that mean the patient's gonna die in exactly 6 months? No. Does that mean the patient's gonna live for 6 months? No. It's a reason. Now, there are certain diagnoses, like cancer, for many of them you can follow a trajectory. Diagnosis like dementia, which qualifies you to have hospice if it's advanced dementia. Obviously, keep it away from your psychotropic medications because that's really bad, but that's a separate discussion. Dementia, okay, has a 55% prediction based on the criteria of Medicare of a 6-month prognosis. 55%. Wow, that's like almost flipping a coin. If it was 50%, then it wouldn't be terminal. They'd have to stay a little longer. So we need to understand this is not perfect, and it's also not sometimes one diagnosis, because many of our patients have a coalescence of multiple diagnoses. So it's a clinical impression that based on this patient's disease and diseases and the trajectory, that in your suspicion, the patient has a prognosis of 6 months or less. That's what's considered to be a terminal patient. And that patient requires information to be given by a healthcare practitioner to the patient and or surrogate. There's another law that they passed called the Palliative Care Access Act. Now that one applies to everyone in this room, including all the hospitals and certified health agencies, CHAs, assisted living, any healthcare institution, basically saying that we as healthcare institutions have to facilitate these goals of care discussions. The fact that has to be in the law is, and again, embarrassing to us as an industry, I think, but it is what it is. So we as healthcare administrators and nursing and whatever else we are in the healthcare sphere have to make sure, because patients have a right to this information and discussion, we have to make sure that we have the resources. Doesn't have to cost you money, but you have to have someone who can actually do it, okay, to have these discussions. And those resources are called doctor or nurse practitioner. That's the Access Act. And the little thing that's tricky about the Access Act is it doesn't mention terminal illness. Because maybe we should be having these discussions before they have a 6-month prognosis. Sometimes by the time a patient has a 6-month prognosis, they are no longer able to be participating in the discussion. But when we made the diagnosis of metastatic pancreatic cancer, and maybe they're going to be one of those unusual ones that lives for a couple of years, why are we not having that discussion when we're making the diagnosis? Does anybody in this room think you're going to live forever? We in the Jewish faith say you should live till 120, because one of the greatest rabbis that ever lived, Moses, lived till 120. That's why we say until 120 years, right? Some of us would not want to live that long because we see what we see every single day. It's probably not so good, but let's just leave that aside. But we recognize that none of us, listen, when I first went into practice, I actually had patients that were born in 1899, 1897. I'm in practice for 25 years. I got to tell you, I haven't seen an 1800 patient in a long time. So that's 120 years. No one lives that long. So that means sooner or later, all of us have to confront the fact that we will, sooner or later, whatever you believe is going to happen afterwards, we're going to meet that fateful end. And that's part of the problem with these goals of care discussions, because if we as healthcare professionals don't have a good thought about what's going to look like for us, then we transfer our social work, transfer our discomfort to the people we're talking to. So we have to make sure that we have a very clear understanding of what our goals and wishes are, that we've communicated that with our loved ones, and we'll talk about that hopefully shortly. But that's really it. So that's all I want to say about the Access Act. I can go into more details about that, but at the end of the day, the one who makes the decision if the patient is alert and awake is